Okay, I think now it's working. Okay, guys. So today is an aortic session, and this is, I think, is very important because I'm sure one session has to be about aortic, and most scenario I think we'll get as an aortic infection or aortoenteric fistula or mycotic aneurysms or rupture aneurysm. You have to get, I think you can ask one of these three scenarios. If they want to be easy on you, they can ask about standard, aortic aneurysm repair or EVAR or juxtarenals. But usually in the exams, they get, especially our third year, they want to know how you deal with emergency, especially with infected aneurysm or mycotics, ruptured AAA, and aortoenteric fistula.
Aortoenteric fistula.
Yeah. So let's start with, let me start, let's see. I know why I'm doing this sound. No, why I'm doing like that. Let's go to case number 6. Any volunteer, or should I pick up somebody? Let me see. And maybe because you see, these 3 cases takes long time, so maybe like 2 guys of you will solve the case, because I want you guys to practice. As I said, this kind of oral exam is not information, it's more practicing. So I want you guys to be sure. So I don't think we can do more than 3 cases. So mostly every case I'll give it to 2 person, okay? So let's start with who's Ahmed? You want to start, Ahmed?
Assalamu alaikum. Okay, let's go.
Okay, Ahmed, go ahead.
A 78-year-old woman presents to the emergency department after a large of hematemesis that has since resolved. She has history of an open AAA repair 10 years ago with a tube graft. A CTA demonstrates thickening of the third portion of the duodenum near the proximal anastomosis distal to the renal arteries. The patient is currently hemodynamically stable.
All right. So the first question will be, so what do you do next?
I will go immediately and evaluate the patient with history and physical examination.
Okay.
Focusing on history, previous episodes of hematemesis or lower GI bleed, history of abdominal pain, and fevers, chills, and
Why did they tell you she came with the blood?
hematemesis.
Sorry. You're right. Okay, sorry. Okay, yeah. Hematemesis. Okay.
That is suspicious for aortoenteric fistula at the proximal anastomosis site. And physical examination, focusing on the chest, abdomen, and peripheral pulses.
Okay. But again, I mean, this is what you think is aortic fistula, but I mean, this is most of it will be because the case examined in real life, still you cannot tell, right? I mean, you can get anything. I mean, it doesn't mean you have aneurysm repair before that you have aortoenteric fistula, right?
Yes.
So you still have to rule out. So don't jump right away to aortoenteric fistula. Like you work up like an upper GI bleed, but most of it is going to end with aortoenteric fistula because an exam. But in real life, you have to work as upper GI bleed, right?
Yeah, correct.
Okay. So you ask about history, no history of prior. Go ahead, read it. Now I read it. No history of prior bleeding or constitutional symptoms. She had some weight loss. And mild abdominal pain. The physical exam is otherwise negative except for epigastric tenderness. What you are worried about? You see now, you should answer now. You see, so what you are worried about?
With a previous history of repair of an aneurysm, I'm concerned about aortoenteric fistula.
Not only because aneurysm, because she has no other when there's no prior bleeding. You see, she has a prior history of bleeding. They will take you more to our GI bleed, maybe ulcer, maybe any other symptoms, but she has no prior bleeding or constitutional symptoms, no weight loss to think about, like,
Cancers.
right. So the reason why you think most probably is aortoenteric fistula. Okay. Let's go to next. So what will be your next step?
This patient deserves an admission. Prior to that, IV cannulas, start with ABCs, cross-match blood, just in case the patient rebleeds, and ask the endoscopist for upper GI endoscopy.
Okay. Why we want to do that?
To rule out a peptic ulcer as a cause. This is in my differential.
Okay. When you want to do it, we're going to do it.
If possible, after admission of the patient, immediately.
You will do it in the endoscopy suite?
If the patient is stable now, yes.
Yes and no. Again, in the exam, you may do it in real life. Exam, you better to be on the safe side. The more you are safe in the exam is better. Like if you are extra safe, nobody will question you why you're extra safe, But, in the real life, you can do whatever you want, So here you think about aortic fistula, right?
Yes.
And you're going to scope her, right?
Yeah.
What if you get like massive bleeding and you are in the endoscopy suite? Okay.
Yeah.
I mean, what you did good. You did like a large pour, you ask you for blood match, cross and match. But if I want to any endoscopy, I'll do it in the OR. Okay. So in the exam, I think you should tell them, because I'm concerned because especially she has no history of GI bleed. So you still think it's high chance that she has aortoenteric fistula, endoscopy, why you do endoscopy? Diagnosis, aortoenteric fistula.
Diagnosis and the treatment if it was of the other differential.
How often you can diagnose aortic fistula with endoscopy?
Not that great unless actively bleeding.
So let's say it's very not sensitive really. It's less than 50% you can really diagnose it with the endoscopy. So you're doing endoscopy not to diagnose aortoenteric fistula because we don't diagnose aortic fistula with a scope. Really to rule out other pathology, you see? So if he asks you why you do it, you don't tell him do it, because if you do it for aortoenteric fistula and you know it's aortoenteric fistula, then you should not do endoscopy because they bleed anytime, they can bleed to death. So really you want to do the endoscopy to rule out other pathology or other source of bleeding. Okay.
Okay.
What usually is the best test to diagnose the aortoenteric fistula?
CTA with triple face.
Okay. Triple A, yeah, CTA angiogram,
Mm.
So do you think you should do that before endoscopy or should endoscopy first?
CTA is my priority.
Yeah, I think I'll do a CTA first, What the sign on CTA?
Contrast extravasation into the bowels.
Oh, this is very rare you see that. If you see that patient also be dead by now,
Yeah.
If you get to this point and it started,
Mm.
then most probably will be dead. So what other signs you see it?
Fat stranding around the third portion of duodenum.
Okay.
Loss of a plane in between the aorta and the bowel.
Correct. And sometimes you can see some gas bubble, outside duodenum. Could be also a sign. But the main thing is a strengthening, as you say, thickening of the duodenum, and you don't see the plane between the aorta and duodenum, and sometimes you see some air bubbles. So all this direct sign of aortoenteric fistula, and sometimes you see extravasation. But again, this is really a late sign, But if you see them, I think sometimes it is enough. Or if you want to be sure-handed more, you can do endoscopy. But again, I will do it in the OR, okay?
Okay.
Okay, here you are. Why the patient in the endoscopy suite, brisk bleeding, you see happened. That what happened. Bleeding ensures that is unable to be controlled by endoscopy. She begin to become hypotensive. What do you do? Like, so
Immediately transfer the patient to the OR for exploration.
For exploration. Okay. I have no problem with that. You can do that. But patients hypotensive.
Hypotension, insert an aortic balloon. I get access and insert a balloon.
Okay.
And start blood.
Okay. We're going to go the more details when we talk about rupture, so I'll leave that later on to explain to me how you do it and all the things. So we'll get that. Is any other? I mean, it's okay. As I'm saying, like in my, I will not do that. I was planning to do something else, but you give me this answer for me. It's okay. It is safe. You take her, you control her, you know. But what other option you can do?
The other option is endovascular pressure balloon, and then until the patient is stabilized, then open her up.
Okay. So what kind of endovascular?
Just intra-aortic balloon, trilobe.
You put intra-aortic balloon.
Yeah.
And then
ask the anesthetist to give the patient the blood. If she is stable, I can temporarily put an aortic cuff until she is fully stable. Then I'll take her as elective as possible.
All right. I mean, it's acceptable. But I don't know. Okay, yeah, it's acceptable. But the most important, put aortic balloon, and then I put a cuff, as you said, and then you stabilize. Then you don't have to open it up. It's different from rupture aneurysm. Rupture aneurysm you have to open up, you know. But this one could be, you know, a good, you know, stabilized technique until you get the patient more stable, because already she lost a lot of blood. You know, maybe she went in DIC now. Platelet is very low. She's cold, so it's not the best time to explore her. So now you put a cuff. You know, you wait a couple, you know, day or two until she's stabilized, then you take her for definite surgery. Correct?
قهوة اليوم ايش فيه؟
هي قهوة اليوم عرض
قهوة اليوم
عرض
All right.
كم قهوة اليوم؟
9 11
11
Okay, you are able to place a cuff below the inner artery and no further extravasation seen on angiogram. What do you do next now?
And then stabilize the patient, give their blood products, and start PPI infusion. Then plan for a definitive surgery with general surgery team.
What you are missing was something important you're missing. You didn't give the patient. Aortic fistula. What does that mean?
triple shot.
PPI. This is one. And
what more things?
Blood products, so antihypertensive medications.
No. Antibiotics, right?
Antibiotics, yes, antibiotics.
Yeah, don't forget that. Aortic fistula is infection, right?
Yeah.
So just keep it in mind. Aortic fistula. So don't forget antibiotic. Okay. Let's go back here. Okay, patient had an echo and a nuclear stress test done recently, which showed mild akinesia of the left ventricle and ejection fraction 35. So it's low. She had felt unwell for the last months, leading to poor oral intake and some weight loss. She's now weight 95 Libra and appear quite frail. So they're going to ask you, what would you do? So she is very ill with poor cardiac function. So how can you treat her now? It's a bit tough question, but that's good to scheme, so you know understand how you deal with that.
Regardless, the patients need a repair because the cuff is just a temporary measure.
Okay.
Eventually,
so how would you repair her now?
I get her as fit as possible, then operate.
What do you do in an operation? What kind of surgery you going to offer her?
I would just go for something extra anatomical and no,
Oh.
extra anatomical bypass and ligation of aorta.
Okay. Why do extranatomical not in situ?
Because of the duodenal complex repair. Otherwise, you will need long time to operate until you reconstruct the aorta and fix the duodenum, and then do in situ bypass, plus risk of infection.
Okay, well, let's forget about the infections. Okay, let's talk about the rings of the surgery. I want something you're not telling me now. So you open her up, right?
Yeah.
We're going to cut the aorta and try to suture it, right?
Yes.
And repair it. And then you have to repair the duodenum, right?
Yes.
So exactly, so the only difference between suturing extranatomical, suturing the stump, and put a tubo graft, it's just one more anastomosis distal, because you have to cut the aorta anyway. You have to suture the stump down, right? You have to suture the distal aorta, right?
Yes.
So really, if you think about it, it's almost the same time, you know? Even sometimes it's easier to do anastomosis than suture the stump.
True.
So how's extranatomical bypass is less invasive? Forget about the infection in situ. But because her poor heart injection was 35, I said I'm going to go with extranatomical, not in situ, not because of the infection. So my question is that when patient has a poor heart function, does the extranatomical bypass is less stress on the heart than in situ?
Since you're clamping the aorta anyway, I think it will be the same. Because longer anastomosis, you'll do through anastomosis.
Okay. So this is not true. The reason why, don't forget, when you do axillo-bifem, you de-stress the heart, right? So when you clamp the aorta, like you're doing nothing, like you clamp the aorta for aortic occlusion. So there's no hemodynamic instability because you have axillo-bifem is open. You see? You see, if you don't have axillo-bifem open and you clamp the aorta, you put a lot of stress on the heart because suddenly you close the half of the aorta. But if you do axillo-bifem before and you clamp the aorta, no stress on the heart because the blood going through the axillo-bifem to lower extremity. So anytime you have patient with a poor ejection fraction, then axillo-bifem is your first choice, not in situ, not because of the infection, because of the stress on the heart. Okay? You understand it?
Yeah, I understand.
So this is the reason why we go to axillo-bifem to decrease stress on the heart. So any patient come with a poor cardiac function and you want to do aortic surgery on him, like infection, graft, aortic fistula, then you do axillo-bifem first, and then you do stump the aorta. You don't do in situ reconstruction not because of the infection, because there's stress on the heart. Okay. So this one, so describe the surgery now. Next question. So how you do a surgery now?
If I'm going to do an axillo-bifem, that's the plan.
Describe. I need to do the steps. So I know again in the oral exam, you're going to get a technical questions because the whole idea of oral exam, I want to know how you do it. You know, so I want you to take me with the steps. How are you going to do it?
Under general anesthesia, prep the chest and abdomen as well as both lower limbs. Start with an infraclavicular incision, dissecting it through the pectoralis minor muscle. Identify the axillary artery, control it.
You're going to go through the right or left?
Right side.
Why not the left?
Because we've been doing on the right.
There's no difference.
No difference, yeah.
There's no difference. But what you have to do before to decide right or left?
Yeah.
You have to check the pulses, right?
Yes.
Be sure they are good pulses because maybe one is less than the other one. You choose the one who has a good pulse. Or you have to do arterial duplex or CT angiogram has to involve the artery. So you have to be sure it has no inflow disease because iliac occlusion, subclavian artery occlusion or stenosis is very common and most of the patients are asymptomatics. So you can just take it for granted. So you tell him before I do axillo-bifem, either I do duplex ultrasound to be sure, you know, or I check the pulse in both arms, be sure they are equal, or you do duplex ultrasound, or you can do a CT angiogram. When you do CT angiogram of abdomen, you be sure that you include the chest and subclavia. So you have to be sure that you have no inflow disease, okay?
Yes.
All right, so then you do axillobifem. So you do an incision and then?
Then control the subclavian artery, open both groins, expose the common femoral arteries both sides.
Okay.
Then start with choose an axillobifem branched graft,
What kind of a graft it is?
a ringed PFA graft,
Okay.
Uh,
What that? Ring what? Can you raise your voice?
PTFE graft.
PTFE graft. Okay. What size?
At least size 8.
Okay. Next.
And then start with the proximal anastomosis.
Okay.
The subclavian tunnel, tunnel underneath the deep to the pectoralis minor muscle, and then get the graft into the right groin, which since I'm
No, just
working
the
correct.
tunneling is very important here. The tunneling. Where you do the tunneling? Because I saw some axillobifem tunneling was very, very bad.
After the first anastomosis.
Tunnel it, huh?
After the first anastomosis, under pressure.
No. What the location? Where you pass your tunnel?
And the anterior axillary
the
line.
back on the where?
Anterior axillary line.
Anterior axillary line is very, very anterior. Mid axillary line. Okay. So you have to be more lateral. So you go mid axillary line all the way down. Okay.
And then pass the other limb into the left to the contralateral femoral.
Okay.
And then do both anastomoses.
Okay. And then?
But prior to that, we forgot to mention to hypnotize the patient.
That's correct. You advise the patient give an ACT. How much you give? We talked about last time.
80 to 100 units per kg. ACT more than 250.
Okay. What else?
Do both anastomoses, femorals. Vent the anastomosis and close the groins and as well as the axillary incision and dress them in order to get into the second part of the surgery.
Well, okay, keep going. You're going in surgery. Keep going all the way. Or you're going home, or you're going to continue?
Okay, then dress both groins and axilla. Go through the midline, open the abdomen, reaching the peritoneum. Open the peritoneum, take the transverse colon up. The small bowel to the right upper quadrant, put a self-retaining retraction system through the retroperitoneum. Open it will be scarred a little bit, and then ask the general surgery team to join in for duodenal repair. However, open the retroperitoneum. You will face the.
Second. So you see the bowel or duodenum stuck to the aneurysms, right?
Yes.
So you dissected, right?
Yeah.
Okay. I mean, let me just, before we say that, are we having a cuff or we don't have a cuff? Because make a difference.
We don't have a patient stable now.
So did you put a cuff before or no? This insisting you describe to me is with or without a cuff?
This is with the cuff already implanted because the patient was unstable previously.
So this one you already put a cuff and now you take her for different surgery, correct?
Yes.
So let me give you a different scenario. Let's say no, patient was stable and she has aortic fistula. I took her for surgery. Okay. There's no axillobifem. You can take right away, or let's say you did axillobifem. So how is different now? You open the belly. What you do? How you do that?
Before that, you will access femoral artery, put a sheath in, and prepare my balloon.
Why you prepare your balloon for what?
For any emergency control of the aorta.
Yeah, but you're going to open the belly, right?
Yeah.
So why need to put a balloon?
Either this or I will have a supraceliac control.
Look, I mean, in the exam, you can't give me either and either. You see, I mean, imagine you are in surgery, Ahmed, as I said, it's different from from written exam. In the oral exam, I want you to read what you do, not what you know. You know.
Okay.
I want you really what you do. If you tell me intra-aortic balloon, I mean, it's not wrong, but I don't know why you want to do it. I mean, you're going to open, unless if you don't know how to do supraciliac, unless if this tell me that you don't know how to do supraciliac clamp. Yes, I mean, if you don't know, you can do aortic occlusion, but if you know, you should do supraciliac clamp, right?
Yes.
So I mean, imagine it's better to tell me that's what you open, and the first thing you go and explore the supraciliac, right? Aorta.
Yeah.
Before you start mobilize the bowel, right? Because start mobilize the bowel, you can get suddenly a lot of bleeding.
A lot of gush bleed. Yes.
Okay, so I'm going to ask you, how do you expose supraciliac aorta? I want to see how you know how to do it.
All right.
Okay.
I will get into the gastrohepatic ligament, then dissect the left lobe of the liver, the triangular ligament and coronary ligaments, retract the left lobe of the liver to the right, and with the NGT in the esophagus, take the esophagus to the left side, and then taking care of not to injure any replaced accessory right hepatic artery, then get the crust of diaphragm dissect.
What you find here, a dense tissue there, what is that? You have to dissect through them.
The liver ligament.
No, the crura, right?
The crura, yeah.
Yeah,
Dissect
because
them.
aorta is the crura, so you have to say, you don't see like aorta right away. You see the crura, so you have to dissect through the crura to get to
Yes.
the aorta, you know?
Yeah.
All right. And then you put your clamp, right?
Yes.
You clamp or you don't clamp?
I prepare the clamp, not.
Okay.
Yeah.
So this is what first you did.
Yes.
Okay. Now let's move down. Now you move down.
Then you move down. They open the retroperitoneum. You dissect the duodenum away.
Okay. So there's now duodenum, and you see like a hole in the duodenum. So what do you do?
I will move it apart. Ask the general surgery team to be on board for repair. Then I will start washing the abdomen.
Okay, just a second. Let's stop you here. Again, I want to understand what you're doing. So you call general surgery. So a general surgery going to fix the bowel first, or you're going to fix
I
the
will fix the aorta first, and then they repair the duodenum.
Okay, but the duodenum is just has a hole. So you are, fixing the aorta, and you have a bile all over.
Yes.
So what do you do?
I will put a bowel clamp on the hole, then wash the area excessively with saline.
Imagine bowel. You see a bowel clamp, how big it is. You did general surgery.
Yeah.
So how is going to fix aneurysms, repair and graft and everything, and this big clamp in front of you? You think it's difficult?
There are smaller clamps, but I can primarily repair temporarily.
Yeah, just get primary repair, close the hole, then you can fix it.
Yeah.
Yes. Get the 3/0 silicone, close the hole.
Yeah.
Okay, and then forget about it, then you can fix it later on. So the first thing is it gets silk 3/0, fix the hole before even go general surgery,
Mm.
The site, finish your surgery, and then they come later on, they can fix it. Okay.
Okay.
All right. So you get the ball out, you open peritoneal. So when you open peritoneum, see, I want to know what the steps. So what do you do after you open peritoneal?
First, expose both dissect both renal arteries. Get an infrarenal.
Just a second. You see, in surgery, you have to make steps.
Okay.
So before you get to the renal artery, what do you see?
But you see, you might come across the the inferior mesenteric vein.
Right. So you have to ligate.
Ligate and divide.
Okay, this is very important, because then after that, what can you see after that?
Then the left renal vein.
Correct.
In front of you. Ligate the suprarenal vein and the gonadal vein. Ligate them for better mobilization.
To mobilize the
left renal vein. Cephal.
Okay. But before you do that, you have to know this for information. If you decide to do that, you want to be sure 100% you're not cutting the, the left renal vein.
Yes.
Okay. Because sometimes it's in your waist, especially extrarenal, so you have to cut it. So when you mobilize the renal vein, you have to decide ahead of time. I'm going to just mobilize it, I'm going to cut it. If you're going to mobilize it, then you have to cut, as you said, the renal vein and the gonadal vein, so you can mobilize it. If you decide to cut it, then you should leave them because this is your collaterals. You should not ligate them. Then you cut the vein, okay?
Yes.
And either you ligate it or you can repair it, whatever you want. But the most important, if your plan is to cut it, don't ligate these collaterals, okay?
Yeah.
All right. Then you identify the right and left renal artery, and then
control them with the vessel loops. Then get your clamp into an infrarenal position.
Okay.
Before clamping, tell the anesthetist that you're going to clamp and to heparinize the patient. Give 80 to 100 units of IV heparin. Wait for an ACT of more than 250. Then start clamping the proximal aorta after getting control as well.
Okay. Well, let's say if you have massive bleeding, so what happened?
In that case, I will clamp the supraceliac aorta.
And then?
Ask the anesthetist to give volumes, and then I move my clamp below the renal arteries when the patient is stable.
You think he has a space? Because aorta, you may have a space. If you do not have a space, most probably you're going to go to the suprarenals,
Supraceliac first, and then
first. But
yeah,
after that, most of you are going to move to suprarenal.
suprarenal, yes.
But most probably is a fistula there. It's hard to put a clamp there, because the fistula will be very close to the renal. So I don't think you have a space unless the fistula is low. But most probably you don't have a space, so you go to suprarenal, and then you have. But I mean, all this you can do during surgery. You can decide on that, But anyway, suprarenal is better than supraceliac. So supraceliac is just temporary.
Yes.
If you decide to keep it for a long time because you can't put infrarenal, then move to suprarenal. Okay, this is what I'm trying to say.
Yeah.
Don't need the supraceliac long time. So if you have no space to put infrarenal, then go to suprarenals and then take the supraceliac out. Okay.
Yeah.
All right. So then you repair.
Get a tube graft.
Go back to the scenario now. Let's go back to the question. Went a little away from that. So this case, what you did, you did axillobiafem, and you're planning to suture the aorta. Okay.
Yeah.
So you went there, you put the clamp, and now you cut the aorta. What else? Continue. So how you suture and all the things. What you do now? Now we talk about the infection, the mycotic, the aorta interfistula.
Okay. You dissected the aorta. Then you put your clamp.
How you suture it? How you close it?
You will need double layer, double closure with 3O proline.
With a 3O proline. Okay, that's good. Let's see what the next question. What is aorta is friable and falling apart when you try to close the stomach?
Then you got to have reinforcing tissues. I would use a tensor fascia lata, and then suture tool and tool. Use it as a pledget.
Or use a pledget. Okay, this makes sense. Yeah. What sort of tissue you said that? At the end of the procedure, you notice some milky drainage accumulating around the aorta. What's coming from?
This is most likely chylus. And then I need to ligate the visible ones.
Okay.
And put a drain.
Okay. You have few lymphatic, ligate them, drain them. You leave some large drain in the abdomen and close on both of the day after starting tube feeding. You notice that drain is putting out a lot of milky fluid now. How you handle that?
I will keep the patient on, rehydrate the patient, replace the losses, and put the patient on medium chain fatty acids.
Okay. I mean, now it depends who's the examiner. The reason why really examiner make a huge difference. How is, these days I will not do that. I will go and do lymphatic coiling, or embolization. This has really become more, but again, the examiner, I don't know what level of examiner will be. So what you're saying is correct, but if he asks you, is there any other possibility, then you tell him about, lymphatic embolizations to start because it's faster and quicker. It comes back positive. What diagnosis? I think they send it for amylase. Yeah, and they for a triglyceride and came back positive. Okay, how you manage it? We talk about it. All right. I think this is a scenario aortic fistula. Again, I mean, the most important, as I said, is that if you're going to open, don't forget to start the supraceliac because You know, when we came similar scenario to the first and second year fellow when we did oral exam last month, and some of the guys they went directly to the fistula and started dissecting fistula, you know, without putting supraciliac clamp. You know, then you get a massive bleeding patient may die. So the first thing you put supraciliac clamp. Okay. All right. Any questions? And then also I need some comment from Muhammad. He's with us.
So the only hi, good morning.
Yes, Muhammad.
So
You
the
have the
only thing I can, when you know, the aorta when you ligate it like that, it's very friable, always friable. So
Yeah,
also reinforced with momentum. So you have to put momentum there.
it's correct.
And a certain percentage of these blow out later on, you know. So that's why sometimes in situ is better than
Yeah.
this just ligating. But in this case, like Dr. Samer said, it's the CHF and the patient is sick, so XFIM, that's the way to go. And then I don't know if they ask this, when you do your XFIM, you cover it with like IOBAN or cover it with a occlusive dressing, so you don't have any contamination from the abdomen also. So you do, you know, you do the XFIM, and then these wounds, you cover them very, very well. So no leakage, nothing, no fluid there. Okay, so.
Muhammad, do you do it the same day or do it the day before?
Depends, you know, you can do it the day before. Depends how much help you have and whatever. So if you have good team, you know, you can double team it and do it. But if not, you know, then you say do it the day before probably.
Okay. Okay.
And it's better for the wounds.
Right. Any question from the fellows about this scenario, this case?
And the other thing, I don't know if I came in a little bit late. Did you talk to them like if somebody's bleeding, you know, with this aortoduodenal fistula, bleeding to death, right on the table, you know, you can put a stent graft in those patients.
Yeah, we went through this scenario
Okay.
that he was in the endoscopy. He had massive bleeding.
Okay.
So what he said, he went there, he put a cuff.
Yeah, I can put a case I've had years ago, patient in GI lab, not GI lab, NG suite for IR for GI bleeding, and he had aortoduodenal fistula right there. You can see it very nicely. I'll put it on the WhatsApp group. It's pretty nice. So, and
How you do it? Did you put a cuff?
they called me and I put a cuff in there. You know, I put a cuff and then
Yeah.
the patient stabilized and we sent her to the ICU. And once she got better, we did it open. So we did an inside
Yeah,
too.
this is really is a new approach. Most people now with aortic fistula, they put a cuff. This as a first, you know.
Yeah.
Until patient becomes stabilized, and then you have a good workup, you know, full workup, and then you can do it on electives. Better than an emergency.
Yeah.
So,
These patients will get better when you put a cuff, they'll get better.
yes.
But if they can't tolerate open surgery, it should be done when they're healthy, when they're good, because
Yeah.
they can reinfect later on. But if they're sick, you leave them alone on lifelong antibiotics.
Yeah, that's true. All right. Any question from the fellow?
I have a question, Dr. Samer.
Yes, please.
Regarding the anticoagulation, since the patient is having an aortoenteric fistula and has been bleeding and hypotensive, would I still give heparin for ECMO?
It's a good question, you know. I mean, it depends how much he blood transfused him, how much he lost blood, because as you said, it go to DIC, you know. So it depends. Are you do it for emergency? Did he lose a huge amount of blood? Did you give him a lot of blood? I mean, I don't like not to give at all, but if he has received a lot of blood transfusion or lost a lot of blood, then I may give him like a small dose. I'll not give him like a full dose. I give it for normal, you know, aortic fistula. But if patient like I take him, he's stabilized, already has a cough, and he's just normal, like you know, didn't receive much blood, and he's stable. His coag is normal. As an elective situation, then I may give him full dose. But if it's an emergency and he's bleeding and he lost a lot of blood, I don't feel comfortable without giving nothing. But I may give a small dose. But I'll ask Muhammad, see what his opinion. Muhammad, what do you think?
I don't give heparin
At all?
in the first day. If it's dry, you know, I give heparin the following morning.
No. She's asking during the procedure, right? This I
For the
understood.
procedure, no, I give. Once she clamp, I give.
Yeah.
Once you clamp, I give. You know, we can reverse it. Remember, you can reverse. Nowadays you can even reverse. The thrombin inhibitors. Even you can reverse the patient. So so you give heparin. Don't worry about it. You clamp first, or you make sure you clamp and you heparinize, and then you give prolamine.
Yeah.
So it's
you clamp first and then you heparinize.
Yeah, you clamp first, and the rupture or these exsanguinate and bleeding, you rupture.
So even with the rupture, you give heparin.
Yeah,
Do you give a full dose or like a small dose?
Yeah, in endovascular, if you do endovascular, what we do if the patient is unstable, we infuse heparinized saline through the sheath as we go, and we go quickly. So that's what we do. But you can give heparin also, and you reverse it.
I see. All right. Any other question? It's a good question, really. All right. Let's go to another scenario.
Morning, Dr. Samer.
Yes, please. Raise your voice, please. Go ahead.
Hello, Dr. Samer. Good morning.
Hello.
This is Ahmed Musa.
Yeah, go ahead.
I have a question for Ahmed Mumattam regarding.
Can you raise your voice, please?
I have a question for Ahmed Mumattam.
Yes, please.
My question is, how many cases of aortoenteric fistula you are facing from the beginning of your fellowship till now?
We've seen only 2.
Only 2 cases?
Yes.
Okay, thank you.
Why are you asking this question?
To know the incidence and rate of these complications in Saudi Arabia.
I mean, incidence not very high, but really you have to know how to handle it. If you didn't see any case, you can tell the examiner, I didn't see any case, so I'm going to tell you from what I read. At least he will not be specific, but this is a kind of emergency. You have to know how to handle it, and you don't have to see it because really it's like an aortic surgery. I mean, the worst scenario, you just go and close the stump. So it's not acceptable to tell me I don't know how to do it because this is an emergency. It's like a rupture aneurysms. You cannot in the exam tell me I don't know how to do it. If thoracoduodenal, I understand, but like if renal rupture aneurysm, mycotic aneurysm, aortic fistula, you have to know how to do it as a technique. So just read about it very well, All right. Well, let's go to scenario number 4. Who want to take this one? Who want to practice? It's volunteer, guys.
Hello, Dr. Samer.
Yeah? Okay.
Yes.
Take this one.
73 years old woman who is currently a heavy smoker present to emergency department with abdominal pain, malaise, and fever for past 2 weeks. This symptom started after recent hospitalization for pneumonia that required IV antibiotic. She is thin in stature and independent of all activity of daily life, living. A CT angio scan was performed that demonstrates infrarenal sacral aneurysm with some wall thickening and pre-aortic fat stranding.
Okay. So she came to the emergency room. So you are in the ER. So what do you do next? As usual, this is the first one you always ask you. What do you do next?
We'll go to assess the patient. We'll start with the history of infection and history of TB, Salmonella, Brucella, and she's came with fever only.
Yeah, and tender abdomen, right? As I said. Right? Yeah. For 2 weeks.
Yeah. Then I'll ask about the history of abdominal pain, site, onset, duration, any surgical history, any family history. We'll ask about connective tissue disease and family history for aneurysm. Then we'll go for examination, vital sign, abdominal cardiopulmonary examination, abdominal examination, lower limb examination include femoral and distal pulses.
Okay, that's enough. So she reported unintentional weight loss over the past few weeks and night sweats. Her pain started the day prior and has been worsening. She has no significant family history. Exam showed tenderness to deep palpation of her abdomen. So what your working diagnosis? What you are thinking she has?
We'll start with the blood workup.
No, I'm saying what your work diagnosis? What do you think she has? This was the question. What is your work diagnosis? What do you think she has?
Abdominal pain, infected aortic aneurysm.
So what we called it?
Mycotic aneurysm.
Yeah, mycotic aneurysm.
Mycotic.
So what your diagnosis is the exam? Just go right to time. What is mycotic aneurysms? Correct.
Mycotic, yes.
There's no graft here. It's not infected graft. It's mycotic aneurysm. Okay. So what workup you do?
We'll start with the blood workup, CBC, blood culture, serology, and inflammatory marker. And echo, can do transesophageal echo and CT plus PET scan.
What else you miss? Very important. Blood culture, right?
Blood culture.
Yeah. So you did a blood culture. You think PET scan is an important?
Yeah, to see if there is infection.
Okay. I mean, yes and no. It depends, you know. If the CT scan finding is very obvious, you know, then you don't need it really, because the CT scan is enough to make a diagnosis. I don't think we'll add it. But if you do it, I have no problems, you know. So what sign you see in CAT scan which tell you it's a mycotic aneurysm?
Very aortic fat stranding with the air bubbles.
So the most of the fat stranding, as you said, I see some bubbles. Sometimes I see fluid collection around it, you know, some air, but this is very rare. So anyway, so the whole idea is that on CT scan, if you are very convinced with the wall thickening and inflammation and air bubbles, then you don't have to do it. If it's not, you still question, then you do a PET scan. I agree with that. I said for WBC, so her WBC 16 and her renal function is normal. Blood culture are bending, her inflammatory markers are both elevated. Her cardiac function is fine. So what's your next step?
Yeah, this patient need admission, start antibiotic, and manage as
what kind of antibiotics?
What, Dr. Samer?
What kind of antibiotics?
According to blood culture.
We have no blood culture. You said blood cultures are bending.
Sugar.
Let me just, somebody talking, me just mute it. Go ahead. Hello?
Yes, Dr. Samer.
Yeah. What kind of antibiotic you give? Just broad spectrum, right? Just empiric. We don't know yet. So you just cover everything, right?
Yeah, right.
So what do you do? So blood culture is still bending, you know, because it takes 2-3 days. I'm going to wait. So just get empiric broad spectrum antibiotic, okay?
Yes.
And this is function. So what your cardiac function is fast. So, oh, sorry, we went fast. So what you do? What's your next step?
This patient need manage asymptomatic mycotic aneurysm. Need surgical intervention.
Okay. How soon?
Urgent.
Right?
Urgent.
Huh?
Urgent.
Urgent. Okay, it's very important. To tell me it's an urgent. It's not an emergency like a rupture. It's also not elective. So you can't stay on that 3-4 days, especially if you have abdominal pain and pain is worsening. You know? I mean, you don't have to do it in the middle of the night, but most of you have to do it next day, okay? It has to be urgent because it's mycotic aneurysm and tenderness, okay?
Okay.
And what you plan, what going to do? What kind? Open repair on the vascular, what kind?
According to the workup cardiac
قالوا لك no يحيى انتبه على السؤال قالوا لك يا your cardiac function is fine so don't waste your time in the oral exam just be specific pay attention what they said and go with that they said your cardiac function is normal so what you plan
for open surgery for repair.
yes yeah open repair what going to do inside to extranatomical what kind of repair
According to the blood culture.
Look, Yahya,
Yes.
it's an oral exam, okay? In real life, you took her next day. Blood culture will not come next day. Blood culture takes 48 hours. We don't have a blood culture, right? So what your plan? I mean, you're planning something, are you going to plan in situ, extranatomical? What your plan? And by the way, whatever you answer is correct as far as you find a reason. Somebody may say in situ, somebody say extranatomical. I have no problem with both, as far as you have any good explanation why you want to do that.
Yeah, for this patient, mycotic aneurysm will do extranatomical.
Okay, you can do that. Even though these days, again, as Muhammad mentioned, most people now, they do in situ because the problem with extranatomical is aortic stump blow up. So most people, they don't do that. Most people do in situ now, the teaching, how you decide on it depends on the of the bacteria and the infections,
Yes.
But again, most people now, they do in situ repair. And now the question, what kind of conduit? When we do exam these days, I'm talking about these I'm saying, I don't know how level of your examiner, but if he's something really he's updated, this should be your first options now, is to do in situ repair. The only time we do extranatomical bypass, in what condition? We talked about the case before. If you have a poor cardiac function, it's the only time we like to do extranatomical bypass. So if you do in situ, then the question is going to ask you what conduit you're going to use.
We use rifampicin soaked Dacron graft or bovine patch.
Okay, these both are fine. What other options?
Homograft or femoral vein.
Okay. So how you decide which one to go?
I say it before rifampicin soaked Dacron graft. I'll use it.
Okay. The answer will be depend on the bacteria and virulence. If you have like strepto, then it'll be like low, virulent, bacteria, then you can go with rifampicin. If really bad bacteria like E. coli or some negative, then you have most of it, you have bovine or femoral vein. And we'll talk about that. So what if her cardiac function is poor? What you do?
Ex-bifam.
Ex-bifam, correct. Okay, let's see what the next question. She agreed to undergo surgery. What special consideration do you when you perform this surgery? So how this surgery is how you do it differently from like normal aortic surgery? So let's go. You open her up. So what do you do differently in this kind of patients?
Aggressive debridement.
Okay, that's very important. And you have to send for culture, right? There's a lot of culture. You have to send for culture. Even you have for strain during the procedure to know what bacteria you're dealing with. It's gram positive or gram negative. Because again, make a difference for the conduit. So you send it for strain to know what bacteria. You don't know exactly, but gram positive or gram negative because make a difference for in conduit. And then you have to do an extensive debridement. Like in normal aneurysm, we put the sac around the graft. I mean, here, no, you have to take the most of the sac out because all the infections. What else you have to do?
So
what is it?
Irrigate with antibiotics, right? A lot. And the last thing, what else you have to do?
Cover with omentum.
Omentum, yes. Cover with the omentum. Just relax in the exam, relax, and you imagine you are in the exam, okay? So yes, you have to cover with the omentum. So you debride a lot. You send for, so what's different from normal surgery is that you debride a lot, most of the wall. You send for culture and stain. You get antibiotics, and you wrap it with omentum. I think this is all very different.
So,
Okay,
so
so let's see. How
Dr.
does
Sam,
the
sorry for interruption. Would they be very picky, like we, they in the American board, they tell you like you have to say like you're gonna resect the sac, basically. I don't know if
you have to resect it.
we resect the sac completely, and they ask you like how do you deal with the lumbars? Like I personally do clips, like I put clips on them, medium clips on the outside, but most
I
people.
usually resect most of it. I leave the posterior wall, but the recommendation to remove the whole thing, even the posterior wall.
The posterior wall sometimes it's very tough to remove, but if you can't get away with the sac, you can remove the whole sac, I
Right.
remove if I can, so.
And you put the omentum around it.
And wrap the whole thing with omentum,
Yeah.
And
Yeah. All right. Thank you. How does the type of the organism matters? We talk about it, right?
Yeah, high or low virulent.
Okay. Which one the less virulent is the positive? Okay, if you have gram negative, it is high, Then if you have a gram negative, so what you do? You know what procedure we do? You know what NICE procedure?
Yeah, femoral pain.
Femoral, correct. Or use a cryopreserved graft, right? Or bovine, but don't use don't use rifampicin inside the graft if you have very bad bacteria. All right, so microbiology result showed the patient had streptococcus pneumonia. So describe the surgery. They wanted to go through the surgery now for mycotic aneurysm. So how you do it? Let's do it very quick, go through it.
Yeah, patient and table start with the midline incision. Transverse colon tracted superiorly and small bowel to the right side. We'll start with at the duodenum ligament dissection the posterior peritoneum. We identified inferior mesenteric vein will ligate. Then we'll identify the left renal vein. We'll decide to retract it superiorly or ligation to preserve gonadal or and adrenal vein. Then I'll prepare both renal dissection and control with the fistula lobe, and prepare for clamp supra at level of suprarenal.
I mean, it's not that. You cannot say suprarenal because maybe it has a good neck. We don't know, right? So you cannot say that. You say it depends how is the neck. If you have a good neck, no, go for renal. Why you get suprarenals, if he's not have a good neck, then you go suprarenals. But if you have a nice neck, I think infrarenal will be better. All right. So then the iliac, then you put a tube graft, okay? And then what else? Well, at the end, what do you do at the end? Again, we go back again. You have to send for a culture, and then you have to wrap it with omentum. Okay?
Omentum, yes.
It's very important. Okay, let's see what it does. Right before you make an incision, your resident tell you that the patient actually have a pseudomonal pneumonia. They're going with the culture because she had this infection after pneumonia. So they're going with the culture of the pneumonia. So now she has a pseudomonal pneumonia, which is a gram, So how you can change your management?
This is low virulent, can continue the same tube graft.
But you can change the graft, right?
To
Because
bovine.
this one, because this is a pseudomonal pneumonia, you cannot use rifampicin. So most of it you're going to use either bovine, cryopreserve on this procedure, right?
Yes.
Okay. There are none of these grafts at your institution. So ما في عندك no graft. ما في عندك لا bovine ولا rifampicin.
We'll use a femoral vein.
Okay, That's good. So use the femoral vein. The aorta is already exposed. Describe key component of the procedure. So let's go to femoral vein. How are you doing this procedure? Can you explain to me? Because they may ask you this question because you mentioned. Did you see it before or la?
No, I don't see it before, but we should preserve the profunda vein and extend it to the popliteal vein.
Say that again, sorry.
And when you take the femoral vein, we should preserve the profunda vein and take the superficial femoral vein to the popliteal.
Correct. But the most important, so you cut it from the popliteal all the way to the common, but just at the common femoral bifurcation, you keep the profunda open. The most important, right?
Yes.
Okay. And then what after? Then you get the vein out. What do you do? How you do aorto by fem?
Reversed.
Reverse it, okay. And then
And start with the proximal anastomosis.
with the aorta and distal anastomosis.
Aortoini and reimplant or used another one for bifurcation.
Okay, where do you get the other one from?
Contralateral.
Contralateral, correct. So most of the time you need to do, if you're going to do bifurcation, you need contralaterals, you know. So you do aortoiliac and then you do jump to the other common iliac, correct?
Yes.
Okay. And then how you do, but you didn't tell me how you expose the femoral vein. You may ask you a question. I mean, common femoral vein. You make a long incision, you can see a lot of muscle.
I will review. I will review.
Yeah, go and review, read it, because you have mobilized sartorius muscle, you know, and you have to go between the muscle to get to the femoral. So you have to know what the muscle you're going to go through them, you know. But and then how you ligate the bird, then you take it out, you know. What if the graft is small? Let's say the aorta is like 20, 25, and the femoral vein is like, let's say 15. So what do you do?
Can use both superficial femoral vein.
Correct, but how you fix them? How you do them? So you get both femoral vein, okay, and you cut them longitudinal, but not all the way, like only halfway or third. Okay,
As pantalon technique.
both the third, each one together. So you have like aorto by fem. You follow me?
Yes, yes, Dr.
So you
Sam.
get two femoral vein, you cut them longitudinal, but only halfway, both sides, and they suture them together. So you have a big one at the top, and you have two tube down. Okay. So this way you deal if it's a small size. If the size is okay, just do aortoiliac, you do a jump. If the size is small, you get two vein, you cut them halfway, suture together, and then you have like aorto by fem. Okay. The problem is that this surgery takes a long time. Imagine this one, and you already aortic surgery is too long. So what some people they do the day before. Okay. How you do the day before? Sorry?
Harvest the vein 1 day before?
No, you cannot harvest the vein the day before because the vein will be dry, right? You cannot keep it 1 day. So what they do is that they open and they, open the muscle, open everything, get the vein, they like it, everything's, all the tributary, but don't cut the vein. Okay? And they just close the skin. So next day when they come, they just, very simple, just put 2 clamp, cut it, and you take it out. You see? So this way you can save a lot of time. So if you're planning as an elective and you're not going to use a vein, then better to do the day before. Expose both femoral vein. And again, dissect everything, like get all the tributaries. Just when you're ready to cut them, don't cut them. Leave them there, close the skin. Next day you open, take them and put them there. Okay? What else? I think that's all we talk about it.
You want to tell them
What
about
else you have to do? Sorry.
compartment syndrome with these patients,
Yes, I want to ask this question exactly. You're right. It's compartment syndrome is very high chance of compartment syndrome with these cases because especially if you ligate both, because you get the venous hypertension. Some people do prophylactic fasciotomy, okay, to be on safe side. Some people wait, but it's better to be, especially if both like to do prophylactic fasciotomy. All right. So let's rewind and say she was too sick to undergo any open procedure. Is there any temporary measurement to treat her aneurysm?
To treat endovascular.
Yes, endovascular. Yeah, even some people now they treat. I'm saying I don't because this exam is different in real life. Lots of people now even they do it, you know, as endovascular, you know. I'll tell you what they usually do. This is some, I think, Dr. Salam from England. He has his algorithm. What he does that he do an endovascular and give antibiotic for 1 year. And after 1 year, he see if patient prolapse, he treated like graft infection. So you go and take it out and do it. If patient did well, he just stop antibiotics. So this is something. But again, in the exam, don't say that. This is more like, you know, controversial. Yeah. So the best way is that you put an EVAR until patient get better, and then you go there and take it out and do a definite surgery.
Yeah.
Okay, we're done. That's good. Hamad, you want to add something, please?
No, they say everything was covered. You know, with the endovascular, I inject rifampin into the graft also. So
yes, that's correct. If you do endovascular, I forgot to mention that. Correct. You do a CT guided drainage, and even you flush with a rifampicin. That's correct. Yeah, right. You go to CT drainage, right? CT guided drainage.
yes. Yeah.
Yes, and
Even in the graft also, I get a needle, like a 18 gauge needle, and literally in the graft I inject, you know,
good.
also. So.
Yeah. Oh, okay.
But it's you know, like you said, these people, if they do better, it's very tempting to operate on them, you know. But if they're healthy and good, you should operate on them. Because a lot of patients, they look good, like 6 months later, they look great, but then certain percentage of them they become sick again, and it's difficult.
Yeah, better to take it out. Yeah. Any question from the fellow?
Thank you, Dr. Samer.
Okay. Well, let's do what last scenario, which is rupture aneurysm, so you can finish with the aorta, because this is usually the most free scenario I think you can get, guys. I mean, we talk most about rupture, but let's go very quick. Who want to take this one? Let's see. Any volunteer?
Can I, Dr. Samer?
Yes, please, go ahead. Yeah, guys, go and practice. Go ahead, please.
So
go ahead.
This is a 78-year-old man presents to the emergency department, hypertensive with an abdominal pain, and is found to have a large AAA on duplex. They immediately call vascular surgery and ask you for your assistance.
Okay. So again, most question, what do you do next? You're in the ER and they call you. So what do you do next?
So I will immediately assess the patient and obtain focused history, asking about the pain, the onset of the pain, the duration, the location of it, and as well as any relative past medical history. Then I will obtain a focused examination by assessing the patient's GCS, his vital signs, and I will examine the chest, abdomen, and the peripheral pulses.
Good. The pain, he told you start acutely 1 hour prior and radiate to his back. Okay. He has no other medical conditions. He's uncomfortable, but maintaining well. Has a tender pulsatile abdominal mass, pedal pulse, tachycardic, and his blood pressure is 100/70. So what do you do next?
Okay, so this.
Yeah.
So I'll start by placing large bore IV access. I will send for labs to get the routine labs, CBC, UE, and type and screen for blood. And then I will get CT angio of the chest and abdomen and pelvis.
Good. CT demonstrate because he's stable, right?
Yeah.
Okay, CT angio. If it's unstable, هنا شوي controversial. I don't want to confuse the exam. But for you guys, unstable, you go right away to the surgery, you know. Or you can put intra-aortic balloon, but that's what they do now. They put intra-aortic balloon pump, intra-aortic balloon. Anyway, let's go with the scenario. CT demonstrate 8 centimeter infrarenal aortic aneurysm with container rupture into retroperitoneal. The neck is about 20 millimeter in length without angulation. The neck diameter is 25 millimeters. and there is healthy, non-disease iliac artery. The physician taking care of him want to start transfusion him because historic pressure is dropped to 90 and he has a rupture. Do you agree with this management?
There is room to allow for permissive hypertension in patients with ruptured AAA, so I will not start transfusion at the moment.
Okay, that's good. You see what I like about your question? You're going exactly to the direct question and you're not talking too much. This is very good. Okay, doing very well. Because just answer and stop. Don't volunteer too much information. Okay, so they cancel that transfusion. Based on the mechanical history and objective finding, what you do next?
So at the moment, I will plan for the intervention.
But before you go, when you talk about presumptive hypotension, when do you decide he really need like pressure really low, you need to do something? And what law is going to say, okay, I'm going to give you transfusion?
I think still blood pressure less than 80.
80? So if he's 75, you give him?
I think so, yes.
Not really. What the most important things?
Is it the map?
Not, no. What the
My
most important
patients,
of your body? What the most important part of your body is your brain, right?
mental status, yes.
Brain is perfused, nothing to worry about it, right?
Yes.
It's the most important. How do you know if the brain is perfused well or not?
The mental status, patient's GCS.
Yes, if patient is talking to you, that's it. Don't worry about pressure. You know, even 70, 80, as far as he's talking to you, he's conscious, you know where he is, I think it's acceptable. The only time you saw what if he start losing, you know, his consciousness, that's the low pressure, then you have really to give him, you know, something. But as far as patient talking to you and he knows where he is and everything, that means the brain is perfused and the pressure is acceptable. Okay, it's better than you go with you can go with the numbers, usually 60 and above, because below 60 people start losing their consciousness. But I prefer to go with like medical exam and say like this patient is conscious and he can talk to you, then I feel comfortable we can continue with hold that transfusion. Okay. All right. So we said what are you going to do next? So based on the clinical history objective, what do you do next? What's your plan?
So I will review the CT to assess whether it's.
We already reviewed the CT and they gave us the numbers.
Okay, so this seems to be suitable for endo graft.
Okay.
So
you're
now
planning for echo for endovascular.
Yeah, echo ECG to see the patient's fitness for endovascular procedure.
No. Look, now you're getting wrong because this is a rupture aneurysms. Okay, it's not the time to go and get an echo and all the things. You know, now you're wasting our time. He may, you know, I mean, he's stable. Yes, we don't know how long he can stay stable. So there's no time for echo. They told you he's fine. When they start the question, let me see what they said. Found to have they immediately vascular ask for assistant. You can, sorry. I got lost. I don't think is a place for this one. You may do an EKG and everything, unless you can do an echo very quick. I mean, I have no problem, but I don't waste my time. This patient has need to go to the OR, okay?
Okay.
And the OR, what your plan is? Say endovascular. Why endovascular? Why not open?
Because the parameters given in the CT suggested that this aneurysm is suitable for endovascular intervention.
Yeah, but why don't do an open? Even suitable for aneurysm, why we do? Now for elective, we do like open. They said open is better. It's almost as good as endovascular.
Better.
It's quicker.
Quicker.
No.
Okay. What else? Which one is better? Endovascular, right? This is the only place where the EVAR shot is much better than the open repair, you know?
Yeah.
You know what the name of the trial done in a state? Yeah, you need to read that, okay? Because it's an important. Because yeah, this is the only place where it's even in the in UK was very conservative. is only when they found that endovascular is better than open repair. Morbidity, mortality is endovascular with rupture aneurysm. So if patient can be fit for endovascular, you have as a recommendation, the first line of treatment is EVAR, not open. Okay. So this been a good candidate for EVAR, then you have to go with an EVAR. Okay. So describe your approach. So how you do it? So you're in the ER, you took him now to the OR. So what do you do?
So needs to be done under local anesthesia
Okay.
and sedation. I will start by obtaining
Why not
percutaneous
general
ultrasound.
anesthesia? It's not easier for you and faster?
It will have an impact on his hemodynamic stability. While he's stable, it is best to go for local first.
No, but maybe you have a good anesthesiologist. He can promise you he will know instability with the general anesthesia. What do you think? You have the best anesthesiologist in the world.
I think I will not take the risk and I will still put him under local.
Why?
If the patient becomes hemodynamically stable, then it will complicate the procedure and will
No,
he
what
will not
happened?
be able to maintain.
Relaxant. You can convert it from contained to free rupture, right? So this is
Yeah.
a problem with the general anesthesia. You can convert it from contained rupture. So always better to do an endovascular with a local, it's safer, you know. Okay, so you did the local. How you do local? You do a cut down, you percutaneous, what do you do?
Percutaneous access.
Okay.
So it will be an ultrasound.
Tell me what the step, because I want to know if you did it or how to do it.
So with ultrasound guidance,
Okay.
I will obtain access through both femoral arteries.
Okay.
Then after inserting my sheath, I can place, before the sheath, I will place the perclose or proglide, and then I will upsize my sheath after placing the wire up to the aortic arch,
Okay.
or actually infrarenal. No, this is abdominal aortic. So to the infrarenals or the renal levels, then I will exchange my sheath to upsize it as per the graft size. And
Just a second. You want to upsize it to the graft size? Okay. Well, keep going. Keep going. Let me see. Go ahead. Keep going.
then I will obtain an angiogram.
Sorry. Go ahead. You're doing good. Doing great.
I'll obtain an angiogram.
Okay.
To assess the renals, the renals and mark them. And then I will insert my device.
Okay.
And
Then you do like a regular EVO. Okay.
Sorry?
All right. Then you do like regular EVAR. You know, you do infrarenal, then you do cannulation control the limb and all the things, right?
Yeah.
Okay, that's good. It's okay. What if you cannot? No, why can I get the limb? Oh no, sorry, we're here. How we do next? You are in the OR, and right before you start, patient became hypotensive and his mental status worsened. What do you do approach now? It's different. So we take him to the OR. Suddenly, before you start, boom, his blood pressure drop down and he become unconscious. So how are you going? What do you do now?
I'll insert an occlusion balloon.
How?
So through my access, sorry, I'll place the balloon in the basically the distal thoracic aorta or supracelia.
You see, I want you the steps, and not what you do. So tell me how it steps.
So I've already obtained my percutaneous access. I have a sheath
Okay.
in. I will pass the balloon
What
through.
size? You see, this is oral exam. This is oral exam, guys. I'm just trying to tell you how the oral exam will be, because they want to know every step is like in real life what you do. So they're going to ask you all this question. So what size?
A 12 French.
Okay. And then?
How long?
How long? You're right.
45 centimeters.
Good.
Okay. And then?
And then I will place it at the supracelic aorta, and I will inflate the balloon there.
And you inflate the balloon.
Yeah.
And then? You tell me a step. Now, how are you going to do an EVA?
Okay, so once
So now
I
you
place
inflate it, you give some time for the anesthesia, right? To catch up on everything.
Yeah, if the
Right.
patient needs to be transfused, he will be transfused, and
Okay.
they will maintain his hemodynamic stability. And after that, I will pass through my main device with the conjugate. And
Just a second. I want to know the steps. Okay. So you have the balloon from the right or left?
the balloon will be from the left, the device will go from the
left.
right.
Okay. So now you're going from the right, correct?
Yes.
Okay. Tell me where you go from the right. So you went from the right, you put your wire with the sheath, and then
So over a stiff wire, the main body will be inserted and placed below the level of the lowest renal.
you do the angiogram and you below the renals. Okay. And
Okay,
then
and then I will plan.
how are you going to control the limb?
So from the contralateral,
Yeah, but you
I'll
have a
take
balloon.
down my
right?
I'll take down my balloon, deflate it, since now I have the graft
You
in.
deflate the balloon.
Actually, I don't think I should deflate because I have to deploy the main body first.
Now you deflate the main body, right?
Yeah, once it's deployed, now I have it tamponading the area of the rupture.
How you tamponade it? Is the other limb still open? You have the short limb of the bifurcated graft, right?
Yeah.
So how you tamponade the bleeding? You follow me, Ma, right?
Yeah, but I don't know really an answer for this question.
So I can, if you want, I put a picture on the WhatsApp group what the sequences were.
You're cheating, Hamad. You cheating.
No. I'm just for them because it's hard to imagine if you haven't done it.
Yeah, you're right. You have to see.
I actually drew this for our fellows, So
that's good. Thank you, Muhammad. Yeah,
just take a look at it.
Technique,
It's a pretty straightforward, but take a look at it,
Yeah,
So
it's good. Look at but I explained to you, as you said, the problem now contralateral limb, because you have a balloon, you cannot do that. So what you do now, after you deploy the main body, you put a second balloon in the main body, and you inflate infrarenal inside the main body. Then you deflate the other one. Okay. Then you can control limb and you finish. Then you deflate the second balloon. So called the double balloon technique.
Yes, and I put the trials also. And I put there's a large VQI study that came, clearly said for endovascular, not everybody should do endovascular. If they're good endovascular candidate, you should do endovascular. If they're bad endovascular candidate, they found the mortality 100%. So you have to do them open. So if you have somebody, not an endovascular candidate, you shouldn't try. You should just do it open. But somebody is endovascular candidate, you should do it endovascular, not open.
That's good.
That's what
he put the picture. It's very nice. So it's called double. You can see picture on WhatsApp. He called double balloon technique. And the trial we talk about it is improved trial. Really, you have to know about improved trial, guys. You need to read about it. This showed that the ruptures, they do better than open repair.
Yeah.
All right. Put to next. So you do double balloon technique. So you have to read about technique, guys, just in case they ask you, because rupture is a very common questions. And so read about it. So what if you cannot connect the contralateral gate? What do you do?
I have an option to convert it to aortoiliac and perform a femoral bypass.
Okay. Or other options? You go from the ipsilateral, right? You put rim catheters and try to get the wire over bifurcation and you snare it, right?
Yeah, or through a brachial axis, go antegrade and try to.
Just again. The first one I talk about, you go from the femoral, cross the, graft bifurcation down, and you snare the wire, right?
Yes.
The third option is to go from the brachial. How you can go the brachial and balloon there, because balloon's still up, because you cannot deflate the balloon until you completely deploy the EVAR. You cannot deflate the balloon. So really going from the arm, I don't think it is an option in the rupture aneurysm,
Okay.
All right. What if none of these maneuvers are successful? You do you said aortoiliac. You mentioned that. you're able to seal the rupture and perform a standard EVAR. You get the patient to ICU, and following morning, the abdomen is tense and he's oligoric despite aggressive fluid resuscitation. What do you think happened and what you do next?
Well, it seems like he has a abdominal compartment syndrome. Here I have to
Correct.
take him back to the OR for decompressive laparotomy and temporary abdominal closure or delayed closure for after
And how you
24 to
measure
40
intra-abdominal compartment?
through Foley's.
Sorry? Okay, what the pressure? Above what?
Above 20.
Above 20 considered rupture. Okay, so what do? You open the belly? And what else? And leave it open,
And
right?
temporary closure, yeah. Leave it open for a delayed closure after 24 to 48 hours.
Correct. All right, it's very good. You see, you did very good.
Yeah, very good.
Any question? Muhammad, if you want to add anything, we see a lot of ruptures.
Just brought it to them, even for the board or for real life. So only 50% of patients actually the candidate for endovascular. Really important, because so you have to come in that mind. So if they're not good endovascular candidate, you do open. Only 50% are when they good with endovascular candidate, basically. Then they're sick. These people are sick. It's not like just you do an EVAR. They go to the ICU. You have to watch them. They get cold legs. They get compartment syndrome. They're very sick, and I would not start doing brachial and things like that on a rupture aneurysm. I would just get in, get out, whatever way, faster to get them out. So
That's good. Yeah, we didn't talk about open, how you do an open, because they ask you how do you open. Let's say he's not candidate for endovascular. So how you do open? Are you still with me? Yeah.
Yeah, here.
So let's say, he's
So-
not, you don't have an EVAR. Let's say you don't have a stent. And he has a good neck, but you don't have an EVAR. You cannot get it. It's not available. So what are you going to do? An open. So how you do an open?
So first, the patient needs to be under general anesthesia. I will inform the anesthetist. Then, since the abdomen is prepped,
Okay,
I
if
will
you want to
create
inform
them-
the general anesthesia, what you should tell the anesthesiologist. Very important.
I will tell the anesthesiologist to
Do not give what?
I think
Muscle
muscle relaxant. Yeah.
Yeah, don't give us relaxant because they can, it's very important. If you decide to do a general, tell the anesthesiologist, please do it without muscle relaxant. If he cannot, then tell him don't intubate until you're ready. Like you prep the patient, your knife in your hand, you're ready to open, and then tell him go and intubate the patient,
or what I do with these, I don't know if that's relevant to the board. I put a balloon in these patients.
Yes.
On the floor or local. Then once the balloon is up, that's like a clamp. I just open after we intubate them and they open after that. But you have to put a balloon or, like he said, so.
I agree with that, Muhammad. Yes, these days, even if you want to do an open, I think it's better to go and put a balloon first, especially if patient is unstable, if a patient is unstable, because again, the moment you open the abdomen, sometimes you just like you convert it from contained to free ruptures. So really these days, if you have a, ultrasound, or you have a C-arm and access to angio suite, or just need a C-arm, better to put an aortic balloon even for open, as Muhammad said. And then after you dissect supraceliac, when you're ready to put supraceliac, you can remove the balloon, or you can even leave it to the end. Yeah. All right. So let's say you open him up. So what are you going to do? How you expose? How are you going to repair? What do you do first?
So I will retract the transverse colon up in the small bowel packet to the right upper quadrant. I will identify the inferior mesenteric vein and ligate.
Tell me what you do. Where are you going to expose first? What do you expose?
So below the renals, I will expose the proximal aorta and create a space for my clamp.
No, but you see, the moment you expose the infrarenal, you're going to get a free rupture because you have to open the omentum, right? The peritoneum. The moment you open it, you see blood come in front of you.
Okay, so I have to obtain
There's no intra-aortic balloon here, okay? I'm talking about an open.
So supraceliac control first.
Yes.
Through the listen stack.
Because guys, a lot of you may not work in a big tertiary care hospital. You make like a small community hospital. You don't have like balloon, you don't have all these things. So you have to be prepared for everything is open. It's different from me or Muhammad who work in big tertiary hospital. Everything is available. But for you guys, you have to know what's open technique. So when you open, the first thing you go before you mobilize anything, you go to the supraceliac aorta.
Yeah.
And you have to know how to expose. We talk about it, how you expose it. You know, the most important to put an NG tube. All right. And then you
Yes.
dissect the crura, and then you put your clamp, and then you expose, then you open the retroctonian and you do everything. But the first step you go, before even Bola is about to go to the supraceliac aorta. Okay? If you
It's a
cannot put the clamp, because what happens sometimes, like pressure is very low, you can't even feel the aorta. You don't know where's the aorta. Sometimes it's very difficult. So what do you do?
I didn't get your question. Before the
Sorry?
clamp, you mean? I didn't get
Yeah,
your
you
question.
go there supraceliac, you want to put a, you can't find the aorta, there's no pulse. Like patient is rotating CPR and no pulse. And you need to clamp the aorta, and you don't feel a pulse because patient is, you know, hypotensive, you know, and it's happened. This scenario happened. It's not like it's not realistic.
I think since the NGT is going through the esophagus, it will help me palpate the esophagus and the
NGT will
aorta.
help. Yes, this one over that to look at the NGT, you go back. But again, remember, there's a lot of crura around the aorta. There is no good pulse. Sometimes it's very hard and very soft aorta. It's very hard, especially young people, to feel it. So if you cannot put a clamp, so what do you do?
Pressure.
Huh?
Digital pressure.
Yes, but you get a sponge stick
Punch stick.
and
Yes.
compress all these areas, you know, until they state the patient. The more they state the patient, get the pulse and blood pressure, it'll be easier to put a clamp. But sometimes if you cannot put a clamp, just get a sponge stick and press hard, you know, or get your assistant to press it until you get a conclusion, you know.
And I
And then you
think
finish after that. The most important when you do aorto, you know, rupture aneurysm, as Muhammad said, you have to get out as soon as possible. The longer you are in surgery, the longer become patient go to DIC, become cold, you get blood transfusion, you know, you went to DIC. So the most important get out of it. What does that mean? You have to do the shortest surgery. So in rupture aneurysm, most of the time we just do a tube graft. Very rare we do aorto biphim or aorto biiliac. Even if the iliac are diseased, are dilated, don't worry about them. Now your priority to get the patient off the table. So unless it's a big aneurysm in the iliac, I will not use the iliac. I just go there and just put a tube graft and get the patient out of the table as soon as possible. The longer you stay in the OR, the longer patient become cold, and then he go to IDIC. Okay? So never do different surgery in the rupture.
and I think Dr. Samer, if they don't know how to expose the supraceliac aorta, they may fail the question, and it's a fair, you know, it's a fair game. You know, like if you don't know how to expose the celiac aorta, you may fail that question. So you gotta know how to do that on
Yes,
board.
it's very important. Yes, because it's an emergency for anything, you know. So really, you have to know, you know, how to expose it, you know.
There is
All
a
right.
Methodist hospital has. I can send that link. They have a series of video procedure exposures there. It's pretty nice, you know. There's a section on how to expose the celiac. I'll look it up. I'll put it up there.
Yeah,
So
send it to them if you can. Send it to the WhatsApp group, Muhammad, if you have it.
I'll look for it right now. So okay,
Yeah,
that's
because sometimes really, especially a patient has no pulse, it's difficult. It's not easy, guys, as expected. So you have to do
مخارج الحروف
many times to do it, you know. All right. I think it's been 1 hour and a half. Any questions, guys, about aorta in general? I think we're done with this session. Maybe next session we'll go to the lower extremity arterial. So this will be like an acute or chronic ischemia. Maybe acute ischemia would be a good subject to talk about it. Any questions?
No, thank you, Dr. Samer.
Thank you, Dr. Sam.
Thank you, Dr. Samer.
Thank you, Muhammad, for coming. Really
Thank you,
appreciate your
Dr.
coming with us. I know you're a very busy guy.
you're
Really
welcome.
appreciate it, Muhammad.
Anytime.
Thank you
Sorry
very
for-
much.
Thank you, Dr. Jabir.
Thank you, everyone. Guys, we may meet like what this weekend. I'm not here. Saturday, Sunday, Monday. I think Monday will be a good. So Monday for me night will be like for you Tuesday. So Tuesday morning. So most will be like next Tuesday morning, because our weekend here Saturday, Sunday. Monday at night will be Tuesday morning. So most will be Tuesday morning. I'll put that on the WhatsApp group, but we'll meet hopefully Tuesday morning. All right, guys. Have a great day.
Thank you.
Thank you, Doctor. Thank you.
Take care, guys.